Now let's talk about anthelmintics. So for the roundworm infestations, the drug of first choice is going to be mebendazole, albendazole, and pyrantel palmoate. And alternative drugs are piperazine, ivermectin, and levamisole. Since this looks like a pill, so PIL. We have a hookworm infestation. So for the hookworm infestation, the drug of first choice is also going to be the same. So it is going to be pyrantel palmoate, mebendazole, and albendazole. An alternative drug is going to be levamisole only. And then we have the threadworm. So for the threadworm, we have the drug of first choice, pyrantel palmoate, mebendazole, and albendazole. An alternative is going to be piperazine. Now let's talk about echinococcus. So for echinococcus, we are only going to give albendazole and mebendazole and not the third one, which was pyrantel palmoate. And for the whipworm, we are going to give mebendazole and albendazole only. And alternative drugs are the same as well. Now let's talk about filariasis. So we give diethylcarbamazine and ivermectin. So you can remember this with di. And alternative drug is going to be albendazole. Now let's talk about guinea worm infection. So this is the only worm infection in which we are going to give metronidazole or flagyl, which is mostly given in diarrhea. And the alternative drug is going to be thiabendazole. Now let's talk about tapeworm infestation. So for tapeworm infestations, we are going to give praziquantel and albendazole. Or alternative drug is going to be albendazole and niclosamide. Now let's talk about the spectrum of action. So 100% cure rate and reduction in the egg count in the roundworm is present, hookworm is present of both of the species, and Enterobius and Trichuris trichiura infestations, but it is much less active against Strongyloides stercoralis. And up to 75% cure has been reported in tapeworms, but H. nana is relatively insensitive. It expels the Trichinella spiralis from intestines, but efficacy in killing the larvae that have migrated is uncertain. Prolonged treatment will cause regression of the hydrated cyst in liver. Treatment after cyst resection of the cyst may prevent regrowth. Now let's talk about the mechanism of action of mebendazole. So the site of action of mebendazole is going to be microtubular protein beta tubulin of the parasite. So there is a protein which is called beta tubulin of the parasite. It is a microtubular protein. So it will bind to the beta tubulin of the susceptible worms with high affinity, and it will inhibit its polymerization. And hatching of the nematode eggs and their larvae are also inhibiting. Ascaris ova are going to be killed. Now let's talk about the pharmacokinetics of mebendazole. It is also important. So the absorption of mebendazole from intestine is minimal, and 75 to 90% of oral dose is passed out in feces. The fraction which is absorbed is secreted mainly as inactive metabolites in urine or feces. Now let's talk about the adverse effects of mebendazole. So it is tolerated in patients with poor health, and diarrhea, nausea, and abdominal pain have attended its use in heavy infestation. Incidence of Ascaris expulsion from the mouth or nose due to worm starvation and slow death have been there. And due to high doses, we can suffer from the problems of allergic reaction, loss of hair, and granulocytopenia. And there is contraindication in pregnancy on the basis of animal data. Now let's talk about the dosage of mebendazole. So for the roundworm, hookworm, and Trichuris trichiura, we have to give 100 mg twice a day for 3 consecutive days, and no fasting or purging is needed. Now let's talk about Enterobius vermicularis. So for enterobiasis, we have to give 100 mg of single dose, which is repeated after 2 to 3 weeks. Now let's talk about albendazole. It has a broad spectrum of action. It has excellent tolerability, and it is a predecessor to a single dose administration. Now let's talk about the pharmacokinetics of albendazole. So the oral absorption is moderate, but it is inconsistent as compared to the mebendazole, where it was minimal. First pass metabolism of albendazole. So the fraction of drug which is absorbed is corrected by first pass metabolism to sulfoxide metabolite. This is active in contrast to metabolites of mebendazole and thiabendazole. Now let's talk about distribution. So albendazole sulfoxide is widely distributed in the body, and it enters the brain. So albendazole is going to enter the brain. Please remember this. So the half-life of albendazole is 8.5 hours. Now let's talk about excretion of albendazole. It is going to be in urine. Okay, so now let's talk about the side effects of albendazole. So it is well tolerated and it has no GIT side effects, and dizziness can be caused. So prolonged use is going to cause headache, fever, alopecia, jaundice, and neutropenia. And clinical uses are in the cases of hookworm, pinworm, roundworm, trichurus trichiura, tapeworm, strongyloids, trichinosis, sarcosis, hydatid disease, and filariasis. Now let's talk about contraindication of albendazole. It is going to be in hepatic disease, renal disease, and pregnancy. Now let's talk about ivermectin. So ivermectin is extremely potent semi-synthetic derivative of anti-nematodal principle, which is obtained from Streptomyces ivermectilis that has been used in other countries for long. Now let's talk about spectrum of action. So it is used for onchocerciasis, strongyloids, Vaccaria bancrofti or bancroftiasis, and Brachian filaria, larva migrans, ascariasis, enterobiasis, and trichuriasis. Now let's talk about the absorption of the pharmacokinetics of ivermectin. Oral absorption is very good in scabies and pediculous treatment. Distribution, it is widely distributed, and metabolism in liver and fat. So plasma half-life is long elimination time with a plasma half-life of 48 to 60 hours. Now let's talk about the mechanism of action. So nematodes develop tonic paralysis when they are exposed to ivermectin. It acts through a second type glutamate-gated chloride channel, which is found only in invertebrates. They're not involved in the motor control of the flukes and the tapeworms, which are unaffected by ivermectin. Differentiation of GABA-minergic transmission in the worms has been observed. The lack of GABA released related actions in man could be due to its low affinity for mammalian GABA receptors and exclusion from the brain, probably by paraglycoprotein-mediated reflux at the blood-brain barrier. Now let's talk about the clinical uses. So filariasis, onchocercosis, scabies, pediculosis, and strongyloidosis. Now let's talk about pyrantel palmoate. It was introduced in 1969 for threadworm infestation in children. Its use soon extended to roundworm and hookworm infestation as well. So now let's talk about its mechanism of action. It will cause the activation of nicotinic cholinergic receptors in the worms, resulting in persistent depolarization, leading to slow developing contracture and spastic paralysis. So worms will be expelled from the body. Only 10 to 15% of an oral dose of pyrantel palmoate is absorbed. This is partly metabolized and excreted in urine. Side effects, it is a safe drug, free of side effects, and occasional GIT symptoms, headache, and dizziness are reported. It is tasteless and it is a non-irritant. Abdominal migration of the worms is not provoked.